Dr. Prashant, you can start your session.
You. Good afternoon, doctors. Welcome on this webinar on the role of Oseltamivir in flu management. Doctors, as you know, this program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have got 30 plus years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries, 21,000 employees globally, and Hetero Healthcare is the largest closely held pharmaceutical company in India. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and we have Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, for which in the year 2020, in fact August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, role of oseltamivir in flu management. We have got Dr. Pramod sir as our moderator, Dr. Sanjay Nathu and Dr. Anil MU as speaker. Welcome, Dr. Zog. Welcome, Dr. Nathu, and welcome, Dr. Anil. Dr. Pramod Zog is Professor of Pediatrics, G.Y. Patil Medical College, Pune. Sir is President IIP 2016, Steering Committee Member GAVI-CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. Dr. Sanjay Nathu is MD DNB Pediatrics, MN AMS FSC EE. Present currently Professor and Head of the Department Pediatrics from March 22 till date in Srimati Kashibai Navle Medical College and General Hospital, Pune. Consultant Pediatrician, Shashwat Hospital, Kothurod, Pune. Areas of interest include pediatric pulmonology, pediatric infectious disease, pediatric emergency medicine. President IIP Pune Branch 2021. Member of Pediatric COVID Task Force Pune Division, organizing team member of numerous national and state pediatric conferences training, member of National Academy of Medical Science India, fellow of Academic College of Emergency Experts, Pediatric Emergency Medicine, member of Indian Academy of Pediatrics and Indian Medical Association. Dr. Anil MU, sir, is MBBS MD Pediatrics, Fellowship in Pediatric Critical Care, Diploma in Allergy and Asthma. Sir is Lead Consultant Pediatrics and Pediatric Critical Care, Spurs Hospital, Bengaluru. With this brief introduction, I welcome all the speakers and moderator, and I hand over the session to Dr. Pramod Zog for further deliberations. Over to you, sir.
Thank you. Thank you. So I will just start sharing my screen from my end. Okay, so just give me a second.
Yes.
So, okay. Okay. Is my screen visible?
Not yet, sir. Yeah, now it is visible.
Visible? Okay.
Yes.
Thank you. Okay, very good. Right. So it's again a nice afternoon, and after the morning practice, I'm sure all our pediatric colleagues are eagerly waiting to listen on the topic of use of oseltamivir in flu management. And I have two influencers for this meeting. One of them is Dr. Sanjay Nathu from Pune and Dr. Anil from Bangalore. And if you can see, every influenza virus has a typical nomenclature. And I have put my name in the form of a nomenclature, which tells you the place of origin, the month and the year of origin, and the strain, etc. And I have been the IAP's presidential strain of 2016. And on the same lines, the influenza virus also has its own strains all over the world every year, and different strains circulate all over the world. And I'm sure everyone knows that the WHO collects the data from different parts of the world and decides the strains of the vaccines to be included in the vaccine every year. We will not be discussing much about the vaccine today in this meeting, but our aim is basically to make our listeners aware of the approach to a child who comes to us with fever, cough, cold, and where we suspect influenza and where we need to use oseltamivir early in the course of illness where we suspect influenza in the epidemiological settings. Okay, so monsoon is still rampant in many parts of our country, and we are witnessing so many cases of respiratory infections, not only influenza but also RSV. And on one side, the mosquito-borne illnesses like dengue are also, seen in a lot of abundance. Okay, so whenever a child is brought for a viral illness, many times, I am worried whether this particular viral illness would turn into something like a cytokine storm which we witnessed during the COVID times, and some of our colleagues have witnessed, these viral infections taking a bad turn after the fifth or the sixth day. And basically, after COVID, the outlook of all the physicians and pediatricians of looking to these viral infections has changed. And Dr. Nathu, will you like to, tell our listeners as to what you think are the possible causes as to the viral infections are showing a different presentation? Maybe what is your experience about the trend of these viral infections in general in India and globally?
Yeah, good evening, everyone. And yes, it's a very good question because nowadays in our practice, we hardly see any bacterial infections, to be really frank. Most of the infections which we are seeing are viral infections, and they have very varied presentations, you can say, starting from the typical mild cold, cough, fever type of symptom to very serious presentations which can result in the patient landing up in the ICU. So probably a lot of vaccines which have come up recently or over the last several years have taken care of many common bacterial infections which used to predominate our patients. And viral infections have now become the most important part of our practice. And as I said, a lot of different type of presentations which we get.
Sure, sure. And I'm sure you would agree with me that, during the COVID times, children did not develop immunity against some of the viruses, which later on started showing themselves up, like the RSV, the adenovirus, the hand, foot, mouth disease. And I remember in some parts of our country, we had outbreaks of measles because, the immunization against measles had suffered. And in the OPD these days, we come across recurrent respiratory infections, otitis media, adenoidal hypertrophy, and unseasonal surge in influenza. And I always say that this adenovirus has become a bad adenovirus with varied presentation and prolonged illness. And many times we have diagnostic dilemmas like CBC and CRP, which are seen on the higher side in any adenovirus. And there are also many therapeutic dilemmas which we'll be discussing in the course of this particular discussion. So basically, we will be discussing about influenza and the early use of oseltamivir. So let us start with a case which presented with fever, cough, cold, and progressive breathlessness over 3 days. And the child had tachypnea, hypoxia, and the X-ray picture was suggestive of acute respiratory distress syndrome. And this child got admitted to the PICU, was ventilated, received oseltamivir along with supportive therapy, and the throat swab came positive for H3N2. He was ventilated for 3 days and then he improved. I'm sure such a picture is not uncommon from different PICUs in our country. And after this particular child was discharged, we were discussing in our meeting as to whether early use of oseltamivir would have prevented all these problems. Okay, so in a previously healthy child coming with cough, cold, and fever and progressing over 3 days, whether the treating clinician could rather prevent this progression, and whether every patient of cough, cold, and fever be given oseltamivir upfront in the flu season. Okay, so there are many points which would lead to some confusion, whether this viral infection or bacterial, whether this virus is a rhinovirus, adenovirus, influenza, or a parainfluenza, or RSV. If it is influenza, whether it is H1N1 or H3N2, and whether one should start oseltamivir upfront to play safe. Okay, so there are quite a few healthcare related challenges during monsoon, and the incidence of influenza and the related deaths is increasing alarmingly in India. Let us know a bit about the influenza virus, which I always call as a naughty influenza virus. Why naughty? Because, as I told you earlier, that it changes its structure every year, and it's an RNA virus. And RNA viruses like COVID and RSV and influenza, they are known to change their structure. And influenza A is the one which causes frequent epidemics due to minor antigenic variations and periodic pandemics. The pandemics are due to major antigenic variation. Influenza B viruses, they infect only humans and they produce local epidemics. They don't produce pandemics, because pandemics are basically the ones where viruses from the human beings and from the birds, they mix themselves up in some third party, like a pig, which acts as a mixing vessel, and a new virus emerges, and that produces the pandemic, against which against these viruses people don't have any immunity. So that's the reason for pandemic. And the two glycoproteins, hemagglutinin and neuraminidase, are the most important parts of this particular virus. This hemagglutinin acts as a molecular key and allows the RNA of the virus to enter into the respiratory epithelial cell. And as any virus would do, it would dictate the RNA of the host cell to replicate itself. Once the copies of these virus RNA are produced inside the respiratory epithelial cell, obviously it would like to get out of the cell and infect other respiratory epithelial cell. Here, the neuraminidase acts as a molecular scissors. It literally cuts the various virions and makes them ready to get out of the respiratory epithelial cell. But the neuraminidase inhibitors like oseltamivir stop this particular process. So the virions cannot exit out of the respiratory epithelial cells and cannot infect the other respiratory epithelial cells. So the progression of the disease is halted. Okay. The four major global pandemics which we have witnessed have been the 1918, 19, the Spanish flu, though it was a misnomer because this pandemic involved a lot many parts of US and other parts of the world. The other one was in 1957, then 68 and 2009, which almost all of us are aware. So, Dr. Anil, do you have any recent update in the epidemiology and the circulating strains of influenza viruses which affect the pediatric population in India?
Yeah, thank you, sir. And good evening, everyone. Sir has already given us the KYC of the influenza viruses. As sir told, we have the influenza A, influenza B, and the influenza C kind of viruses. So going by my experience here in Bangalore and what my colleagues are facing throughout the country, we have had quite a bit of influenza this season. This started probably immediately after monsoon, probably June, July it started, and probably it peaked during the September and October month. Probably it's come down to make way for other viruses like what sir discussed. And we do have the seasonal flu viruses also and the pandemic variants also. So currently what is going around right now is the H3N2 variants are there quite a bit, and H1N1 we are getting positive. Very less of influenza B, I should say. So as we know that these lineages are numbered, like the based on the hemagglutinin and the neuraminidase, it is numbered as H3, H1, H9 and all. Usually H9 and all, these are the pandemic varieties, whereas the local varieties which are causing the local epidemics are the H3N2 and H1N1 right now. And very less of type B we are getting. Influenza B is quite less this season.
Thank you. As everyone is probably aware, the flu virus is transmitted by people up to about 6 feet away. And these viruses are spread mainly by the droplets made when people with flu cough, sneeze, or talk. And the droplets can land in the mouth or the nose of the people who are nearby, and they are the ones which are inhaled into the lungs. And Dr. Nathu, what are the different clinical scenarios with which influenza virus can present in the pediatric population? In short, when to suspect influenza infection?
Right. So the commonest presentation which we all know is the typical cough, cold, throat pain, running nose, body ache type of presentation. Headache is also quite prominently seen, and most of our patients, pediatric patients, do have this common presentation. However, like in this year, as Dr. Anil was pointing out, a lot of flu cases we have seen, and any child with a febrile respiratory infection, the back of our mind, we had a thought that this could be influenza because it was very commonly isolated in many of our patients. Having said that, there have been atypical presentations which do present, especially at an institution level. For example, we had a couple of cases of febrile seizures who, on investigating for the cause of fever, were found out to be influenza A positive. One patient of encephalopathy, and though I have not seen, myocarditis has been also described with influenza. Just last 15 days back, I had a patient who had gastroenteritis and was in severe prostration, a 3-4 year old child, and with fever, obviously. And the cause of fever was not apparent. It was not a typical presentation. Still, we did the throat and the nasopharyngeal swab, and it turned out to be influenza H1N1. So yes, gastrointestinal presentations are also seen with vomiting and diarrhea, and hence in a situation where the number of cases in the community are very high, any child presenting with fever, one has to think in terms of possibility of influenza.
Great, very good. So maybe if I add to what you said, basically influenza being a viral illness will show all the features of a typical viral illness where there will be generalized infection of the respiratory system. So from the nose down to the lungs, any part can be involved. And as we know, a virus can affect multiple systems in the same child. So the presentation of vomiting and diarrhea that you saw maybe a part of the viral infection. And in the practice, I'm sure everyone has noticed these children have severe headache and weakness and very high fever to begin with, to such an extent that many times the parents have to literally lift up even the older children because they are unable to walk because of sometimes the muscle pain and weakness. So when we get a child who has influenza-like illness, I always say that typical influenza is the father of all those influenza-like illnesses because of these presentations. And many times it's not very difficult to suspect influenza, particularly when family members are also there who are infected with influenza and they also have similar presentations. And there are different illnesses which are close to each other, like influenza-like illnesses, H1N1, severe acute respiratory infections, and COVID-19. And as I said, each one has its own little different features, but in general, the presentation, it's very difficult to differentiate, these different viral infections. Though one should be aware about influenza because it is one of the eminently treatable viral infections. Okay, so Dr. Anil, will you like to tell our listeners a bit about the emergency warning signs of the influenza?
Yes, sir. Emergency warning signs or the so-called red flag signs are very, very important for us as a practicing pediatrician. When we see children who are lesser sick in the OPD, we should always reiterate the parents telling that these are the red flag signs that you should watch out for. Usually, the most important thing is how is the child doing in the interfebrile period? That matters most. If the child is still active with a good oral intake, that means the child is generally doing fine. So the red flags that we usually look at is if the child is becoming very lethargic, very tired in the interfebrile period, the oral intake starts coming down, and we start looking system wise, probably in the respiratory system, we do see that the child starts having little tachypnea, and probably the cough becomes incessant, and so much so that the child is unable to maintain the oral intake. And CNS wise, if you look at it, the child starts becoming very lethargic, very drowsy, very sleepy in the interfebrile period also. So these are the most common red flag signs that we see. And of course, for the very severe fevers, they may have too much of drowsiness, seizures, like what sir told, like febrile seizure, the child may have, child may start becoming more lethargic. These are the red flag signs. And of course, like in our respiratory program, like we say, tachypnea, which is inappropriate for age, chest retractions, fast breathing, incessant cough. These are the danger signs that we look at.
Thank you. And one should be aware that influenza is associated with complications. And most of these, they start with the alphabet A, like ARI, acute respiratory infection in the form of pneumonia, or ARDS, acute otitis media, absenteeism from the schools, and antibiotic abuse. It is necessary to note that most of these viral infections, they set a stage for the superadded bacterial infections because they produce the epithelial damage. We all know that quite a few cases of influenza they have superadded infection with Streptococcus pneumoniae or Staphylococcus aureus. Even with RSV, we know that there are cases of pneumonia, bacterial pneumonias, which get, as a superadded infection. So these viral infections, they set a stage where secondary bacterial infections can occur. And that is many times the cause of confusion when a child with typical presentation like a viral illness fails to improve or worsens. And we'll discuss a few cases related to this situation in the latter part of our discussion. So let us come to the treatment of influenza. And Dr. Nathu, I will like you to elaborate a bit about the treatment of influenza based on the categorization of influenza into categories A, B, and C. Yeah.
Right. So the basic treatment of influenza is supportive. Obviously, a lot of rest is required. Adequate hydration is very important with all homemade fluids. I don't see any role of any cough suppressants, but of course, paracetamol is commonly required. And then the symptomatology or the type of patients have been categorized into three types. The category A is the typical influenza patient which has mild sort of symptoms. So mild fever, cough, cold, coryza, or mild headache and body ache, but otherwise a well child. And this type of child usually does not require any specific antiviral therapy, neither does it need to be tested for influenza because this is expected to recover in 2-3 days, and though the child may have some malaise for a longer time. Uh, the type category B type of patients, in that you tend to have a very high fever, a severe throat pain, and with that there may be some other comorbidities, you can say. For example, a person who is an elderly person or a child who is less than 5 or especially less than 2 year old would be taken as a category B. At the same time, a child who also has some other condition, for example, he is an asthmatic or he has some chronic neurological disorder or some kidney disorder, or he is on a long-term steroid therapy, immunocompromised. So all these patients would come into category B. And if such patient presents to us, we would definitely like to start him on the specific antiviral, that is Oseltamivir, at the earliest. And I would not be very aggressive about testing. If possible, test, but if not, it is not mandatory to test these patients. You need to treat symptomatically. You need to start Oseltamivir early, and that should take care of the patient. The category C is the most severe type of disease. So in addition to the symptoms which I already described for category A and B, this child will have systemic problems which are indicating a severe, or as Dr. Anil was saying, red flag signs. For example, the child is breathless, tachypneic, has hypoxia, so the saturations are not being maintained, is severely prostrated with a poor intake, poor urine output, hypotensive, or lethargic. So all these type of patients are in a severe situation. They are categorized as category C. So in such situation, definitely oseltamivir needs to be started upfront as soon as possible. And these type of patients also ideally need to be tested for the nasopharyngeal swab to establish that and confirm the diagnosis of influenza. Of course, these category C patients usually go to the ICU and they require very close monitoring as well as very intensive supportive therapy to get them out of the situation. So, as I said, category A and B, not very keen to test the patient. Category C, definitely testing is required. And category B and category C, I would like to start oseltamivir as soon as possible. Otherwise, it is basically supportive treatment for all the categories, especially for category A. Only supportive treatment would be required.
Very good. So this categorization has definitely helped us in managing children. And of course, you would agree with me that for the control of fever, this paracetamol is the drug of choice. And we all know that, aspirin is the antipyretic, which needs to be avoided because it is associated with problems like Reye syndrome. And let's see a bit about the molecule Oseltamivir before we proceed further with some cases. So basically, as I told you earlier, it's a neuraminidase inhibitor and it blocks the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. Basically, it's a potent and a selective inhibitor of this neuraminidase enzyme, and it's a prodrug. It is converted into the active form oseltamivir carboxylate in the liver, and it inhibits the virus replication and the pathogenicity and the further spread of infection. It was the first oral neuraminidase inhibitor and it has been approved in more than 100 countries. It has been approved by CDC, American Academy of Pediatrics. So we have already seen the different categories and the treatment guidelines, and we will have a quick look at the dosage and the recommendations of oseltamivir. So for adults, it is given in the dose of 75 milligrams capsule twice daily as a part of therapy, and 75 milligram capsule once daily as a part of chemoprophylaxis. In children, the dosage depends on the weight bands between up to 15 kg, 15 to 23, 23 to 40, and above 40. And again, for therapy, it is given as a twice daily dose, and for chemoprophylaxis, it is given as a once daily dose. In infants, the dose is 3 milligrams per kg twice daily under the age of 1 year, and in infants, chemoprophylaxis is not applicable. Dr. Anil, how does early initiation of oseltamivir influence the clinical outcome of influenza?
Yes, sir. Like what has been already discussed, what we saw is the treatment is mainly symptomatic and supportive care in the mild cases. But what's the advantage of starting this in the category B and category C? Multiple studies have shown that starting oseltamivir early in the course of illness, that is typically on day 1 or day 2, say before 48 hours, if at all the oseltamivir is started, it shortens the duration of the illness. So for someone who has gone through a flu-like illness or the influenza, they will vouch for it, for the severe body pain, headache, sore throat, the discomfort, the lethargy it causes. Even that 1 to 2 days of quick recovery means quite a bit for the patient. So, and more importantly, like sir, what you discussed, it prevents the progression of illness into a much more complicated kind of a scenario. So, starting oseltamivir early in the course of illness, we are able to shorten the duration by 1 to 2 days. That's what multiple studies have told. And also it prevents the complications from happening. And for us who are working in the institutes, like where we do receive lots of referred cases, so the references may happen by day 4, day 5, or when there is clinical worsening or the red flag signs appear. So even for those patients who are referred to us on day 4, day 5, with the background of strong epidemic of influenza that is going on and the clinical picture of influenza like illness, I think we should not hesitate to start even on day 4, day 5 to give them the benefit so that we stop the progression of the illness. So for the inpatients who are in category B and C, we don't hesitate even to start even on day 4 to day 5 to prevent the progression.
Right. And let us have a look at some benefits of the empiric and the early use of oseltamivir. And there have been quite a few clinical trials. And in patients with influenza, oseltamivir reduces the antibiotic use, influenza-related lower respiratory tract complications, and hospitalization. And this is not true for infants and children, but also for adults. And just wanted to know, Dr. Nathu, whether we can start oseltamivir empirically or whether we need to start it only after investigations.
So I think as we have already discussed, in the patient who is presenting with severe symptoms, there is no question of waiting for the investigations and report in a given epidemiological situation where influenza is quite commonly being seen. It should be started empirically. Even for, as we discussed, category B type of patients who have a severe type of presentation, even in them, there is no point waiting for the investigations and then starting. As has been discussed earlier, we start, the better the outcomes, the better the duration of the disease. And so investigations are not mandatory. Category C patients who are in the ICU admitted, they can of course be investigated parallelly, but starting oseltamivir should not depend on the investigations.
Okay, that's great. And guideline recommendations, even from WHO, support what we are discussing. So it is said that empiric treatment is strongly recommended. The treatment should be started as soon as possible. Laboratory confirmation is not necessary for initiation of therapy, and negative laboratory test for H1N1 does not exclude the diagnosis, and that's why early therapy is very, very important. And let us have a look at some cases just to clarify some of the concepts related to the management. So this is a child who has come to us with fever for 3 days, cold and cough, and he has been on metered dose inhaler since 4 months. He is well controlled and he has received symptomatic treatment. He comes back after 3 days. He has been afebrile for a day and the fever has developed again. And in between, he has been quite active. Obviously, this is a child who has come for a recurrence of the viral upper respiratory infection. And as we said earlier, these have become more frequent and are occurring at a shorter interval. So when such a child comes to the OPD, Dr. Anil, how would you counsel the parents about this particular scenario? Yeah.
Yes, sir. This is the patient. Probably all of us do see this. Every alternate patient is like this acute febrile respiratory kind of an illness. The child is active in between the fevers and has been going through this multiple such episodes over the last few months, probably. And this is very, very typical. The anxiety of the patient is quite high, even though we know this, even in the influenza, the background of influenza, this will be a category A kind of a patient where just symptomatic supportive care and reassurance is all that is required in such a patient. I think we should spend a couple of minutes here to address the parental concerns or the anxieties that are there. For a patient like this who is presenting, I think it's the exposure probably the child is getting from the preschool or from the nursery, that nowadays children are being sent to these kind of schools very early in their age, and then they get exposed to multiple such viruses, so their immunity is being challenged by multiple such viruses. They may have run these minor respiratory illnesses. I think we should educate the parents, telling that this is, look, this is quite common. This is how the child is growing, and even the immunity is growing. Immunity is learning to handle all these minor respiratory infections, and just symptomatic supportive care is what is required. We'll always explain them the red flags and tell them, if at all there's anything, please do come back. We are always there. After 24, 48 hours, we can review your child and then take a decision for further management. This is the way I think I would counsel this patient.
Yeah, sure. And Dr. Sanjay, do you have any additional points to add to what Dr. Anil said?
No, absolutely spot on. And the most important point here, which he mentioned, is the follow-up, because the patient needs to be called back to have a look yourself that the child is recovering and not worsening. And as was rightly pointed out, we are seeing patients who are getting these infections one after the another. Like last couple of months, we have seen several such patients who have come to us almost weekly with a new fresh infection sort of thing. And the urge is always to start the antibiotic, but as this rightly said, antibiotics are not required. And if it's a mild presentation, even the antiviral is not required. But spending the time with the patients and explaining to them the situation, why the child is getting these recurrent infections, is what is the most important part.
Yeah. So it's very easy to convince the parents, by telling them that about 8 to 10 viral upper respiratory infections are normal in a child who is growing. So this growth chart, which I am sure you would agree with me, will help us in convincing them that, see, on one side the child is growing very well, and these infections are a part of growing. And I remember Dr. Anil telling me last time, that take this cold and cough as a member of your family, right? So it's an additional member of family. So till the child is growing, the infections will always continue to be there in the family. Okay, so it's important that you spend a bit of a time with the parents, and this will only help you avoiding the use of antibiotics. Okay, because it is, I know quite a few pediatricians, they find it difficult how to explain to the parents as to how to avoid. Otherwise, when the OPD is busy, they simply put down the pen on the letterhead and start amoxicillin or anything, so that is something which we need to avoid. And if you spend a minute extra, I think parents can very well be convinced. And in fact, there are parents who would in fact love that antibiotics are not prescribed. So there is a section of parents who is very happy when antibiotics are not given. Okay, at the same time, let us try to find out whether we can at least try to have an educated guess about some of these common organisms which affect the respiratory system. So every one of us is probably aware that when there is simply cold or sneezing and the child is otherwise playful, not exhausted, and there is mild or no fever, then it's likely to be a virus like a rhinovirus. And as we said, flu has many those systemic symptoms like high fever, prominent headache, myalgia, extreme exhaustion. And adenovirus is a different ball game, which comes with pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, and sometimes hemorrhagic cystitis. Bronchiolitis related to RSV is common under the age of 2 years, particularly under the age of 1 year. And many times we know that influenza and RSV can coexist. And some bacteria like group A beta hemolytic streptococcus can produce fever, follicular tonsillitis, and tender cervical nodes. Pneumococcus can come with fever, grunting, tachypnea, and staph can come with rapid progression and toxic look and toxic progression. Okay, mycoplasma usually involves little while above 5 years, though in some parts of our country it is seen even above 3 years, and it can come with predominant cough. Okay, so Dr. Nathu, this is a 4-year-old child which came for cough and fever of high grade since 5 days. He was not settling with oral medications, and on admission, he had tachypnea and needed oxygen support. And this child had hemoglobin of 11.6, total count 1620, and platelets were 132,000. The liver function tests were slightly deranged, and nasopharyngeal aspirate was positive for H3N2. So this was a child who had influenza with low WBC count and a low platelet count. So I would just like you to analyze, maybe dissect out this particular case for the benefit of our listeners, because this could be a common case in their OPD.
Right. So the presentation was of cough, high grade fever since 5 days. So significant time duration since the onset of symptoms, and he had tried simple oral medicines, but they were not worked. Since the child was tachypnic, obviously oxygen was started, and X-ray, which has been done, shows quite a significant finding on the right side, especially, and a few infiltrates on the left side as well. So in a situation like this, we would definitely think in terms of possibility of influenza, and start the child on supportive measures, oxygen plus oseltamivir. And the labs which are showing a low WBC and low platelet count. So especially in this year, we had several patients who are presented with leukopenia and thrombocytopenia, and some of them do have respiratory symptoms like this child, some do not, and we always end up also trying to rule out the possibility of dengue. So yes, influenza can present with low WBC and low platelet like in this patient. And we have to look at possibility of influenza because of the high number of patients which we are seeing in the community.
Very good. Dr. Anil, do you have any inputs as an intensivist in this particular child coming with such a presentation?
No, sir. Syndromic diagnosis on day one before we get a swab, we know it's a acute respiratory viral kind of illness, probably ILI with the backdrop of the epidemic that's going on. And probably we would get this child started with oseltamivir, with or without the swab. Oseltamivir we do start with. Once we get the labs in X-ray in few hours, we know that it's more like a viral kind of illness. But if someone is sick enough to be having tachypnea, retractions, and requiring oxygen, probably after taking the appropriate cultures, we would probably start on first line of respiratory antibiotics, probably coamoxiclav, and then probably, like Sir told, yes, definitely we do have a co-infection of dengue sometimes, and we need to rule out the dengue. And once the cultures are all negative, I think then we can take a call about withdrawing the antibiotics later on after say 24, 48 hours. Once the cultures are negative, then we can decide about the antibiotics later on.
Okay.
So antibiotics
So-
preferably reserved for severe cases who land up in the ICU.
Correct.
Otherwise, we should try and avoid.
Yeah, if they're tachypnic requiring oxygen, I think it's okay to start, and then we can always de-escalate. Point taken, sir.
Sure. So this is another child who presented with fever for 5 days. Fever was not settling. The counts were normal, and the nasopharyngeal aspirate showed H3N2. Another child which came with cough, cold, and fever with normal counts, but the CRP was on higher side, and the aspirate again showed H3N2. Dr. Anil, what are the factors on which the clinical response to oseltamivir depend?
Yes, sir. Already, I think we discussed this, touched upon this thing. The single most factor is how early we do suspect this viral kind of influenza-like illness, influenza, and then start with oseltamivir. So if it is started early in the course of illness, within 24 hours or 48 hours, if you are able to start, then we get the best response. Usually, we do see that after 24 to 48 hours of starting the appropriate antiviral, that is oseltamivir, influenza cases, there is a sense of well-being which starts, and the fever starts responding, the tachypnea and the respiratory signs will start coming down. So I think the single most point is how early we get started with oseltamivir. It's a timing of starting oseltamivir. It's what matters.
Right. Now, why I asked you this question is because I came across quite a few pediatricians who were hesitant, or they were not very much in favor of starting oseltamivir early, probably not being convinced about the diagnosis, or maybe some other factors. So, have you come across such a situation where people are hesitant in starting medication like oseltamivir in your practice? Do you
Ye-
think?
Yes, sir. Especially in metros and all, like we do, because we do get swabs routinely done. We know the load of flu that is going around, which virus is going around, because if it's a multiplex PCR, we do get to know sometimes. But I think keeping in mind the places where there is no access to get the testing done, or the affordability becomes an issue. Many a times it is not done and not thought of. They keep on thinking it's a bacterial kind of a situation. Start with antibiotic, escalate the antibiotics, and many a times, because as you rightly told, it's a neuraminidase inhibitor. So it prevents the spread of the virions in the virus. It spreads the complications. It stops the complication of the disease early if it is started. So I think always we should have the doubt that it could be influenza like illness, probably because of influenza, and we should start it soon, as soon as possible, because it's a very well tolerated drug, very safe drug, also very simple to administer kind of a drug. So I think, like what sir told, even if we are not getting the testing done, I think we should go ahead and start the child deserving children on oseltamivir.
The
Thank
only
you for that.
slight issue this time which we are having is the repeated episodes which the child is presenting with. So there has been an odd patient who has had to take the medicine 2 times in 2 months. So that is where the patients may become a little reluctant. And in these situations, it is always better to test to convince them. But otherwise, yes, we need to give, and not many patients, fortunately, are very reluctant to take the medicines.
You're right. Yeah. So, of course, this was a child, little, a child who deceived us, because, he had 4 year a child which came with cold and cough, with high WBC count and high CRP of 136, with continuous high fever, and turned out to be adenovirus positive. This is a girl, 5 year old, with high fever for 5 days, cough and cold for 5 days, sick with mild wheeze and no crepitations. So, Dr. Natu, looking at this case scenario, how will you approach? Will you put this child on antibiotics, and what do you think you would do in this case?
So, as was discussed initially by Dr. Anil, we would look at the certain things like how are the other members of the family, the epidemiological situation, are there other cases in the family? How is the child in the interfebrile period? Is she sick even in the interfebrile period, or she is active? And then examine, of course, the child, look for any systemic findings, see if there are any red flag signs. And if there is no red flag sign and the child is otherwise active in the interfebrile period, we would probably give just a supportive treatment. I would not be very keen on starting an antibiotic because we have seen viral infections lasting 5-6 days also very commonly, and they do recover. Of course, with a high fever and if the symptoms are severe, I would probably think of starting oseltamivir, but refrain in starting antibiotics.
Okay. Actually, this child, maybe because the child had high fever for 5 days and was sick, probably the pediatrician put this child on amoxiclav. The WBC count was 2800. The neutrophils were 10, lymphocytes were 70, CRP was 34.7, and the child was put on oseltamivir, as you earlier said. But the nasopharyngeal swab turned out to be showing rhinovirus. Okay. Dr. Natu, will you like to comment a bit about these tests which are done for the diagnosis of these viruses and the treatment decisions which are taken by our colleagues?
Right. So, as we discussed, tests are not justified for all sorts of patients. Maybe probably in the severely ill patients, we should definitely test. And the method of testing also carries a little bit of importance, because with the swab, the nasopharyngeal swab is not taken properly, then you may end up with a result which is not very reliable. Otherwise, in a patient in which the swab has been taken properly, the multiplex tests which are done nowadays, they are quite reliable, and we do get good results which correlate with the clinical findings as well. In the city of Pune, we are lucky to have NIV. So we do send a lot of our patients swabs to the NIV, and the results are quite reliable, obviously. So yes, testing is good if done properly. It is quite reliable, but not necessary for most of our patients.
Okay. Dr. Anil, do you have any comments about the tests which are done for the diagnosis?
Yes, sir. Especially after COVID, I think the PCR technology has picked up quite a bit in our country, and even PCR testing is available in nooks and corners of the country. Of course, the premier like NIV, if sir has the access, there is nothing like it. And even the smaller labs have started doing multiplex PCRs for all these respiratory kind of illness. So many a times, like what is shown here in this slide, there may be other viruses which may pop up, like rhinovirus. But I think always we should have a clinical suspicion in mind. As we know, rhinovirus, it's more of a localized kind of a infection that comes with a mild febrile illness, mild runny nose, and it gets better. And usually rhinoviruses are the ones which trouble our small babies. So in a child, if you're getting for a 5-year-old rhinovirus, probably it is there just like an innocent bystander. But if there is a strong suspicion of influenza or influenza-like illness, I think we should go ahead and start this child on empirical Oseltamivir also. And here, the sensitivity is almost 95% in a well-done swab, in a nasopharyngeal aspirate. If it is collected very well, the sensitivity may be as high as 95% also, and the specificity is close to 100%. So I think a well-taken swab from deep in the nasopharynx or from the pharyngeal secretions will give us a better answer.
So this is another child, 7-year-old daughter of an IT sector parent, and coming for high fever for 3 days with throat irritation. The child has examination 2 days later. The throat is showing mild congestion. The child has been given paracetamol, and with the flu and the adenovirus, going on in the atmosphere, the decision about investigations and taking a throat swab and starting empiric oseltamivir, and particularly being a daughter of the IT sector parent, the pediatrician is really puzzled. Dr. Nathu, how would you proceed in such a case? What will you do?
So if the patient is having symptoms which are of a severe nature, of course, with the supportive management, I would definitely think of starting oseltamivir right away, because earlier we start, the better results we are likely to get. So if the fever is high, if the throat pain is quite severe, and the child is looking a little dull, prostrated, then I would definitely think of starting oseltamivir along with the supportive treatment.
Okay.
About the investigations, I would not be too keen. Would not add much to the situation right now.
Right. Dr. Anil, what would be your approach in such a child?
Sir, I think we will still stick to our category A, B, and C. If it is still in category A, we would still counsel them, no need for testing. We will try to push the investigations as much as possible. We'll explain them the clinical scenario. Like what sir told, if there is a very severe suspicion of a influenza-like illness, yes, it's we are okay to start with empirical oseltamivir. We'll always call them back in say 24, 48 hours. And if they still insist, just to give them some peace of mind, probably we'll ask for a testing to be done, nasopharyngeal swab testing. Otherwise, I think more time spent in counseling and explaining them the just paracetamol hydration is good enough. We will observe, wait and watch. I think that should do.
Right. And as I can see, these are IT sector parents, which are common in Bangalore as well as in Pune, and they are not the information and technology sector, but they are the inquisitive and troublesome sector also sometimes. So, though of course sometimes we do enjoy these discussions with these parents, but sometimes they are over inquisitive. So we have to be very very careful, because whatever discussion we are doing, many times they are well read and they know most of these points and they may cross question you. So today's symposium, the webinar will definitely help our listeners to answer the queries of the IT sector parents also. Okay, so this is a 3-year-old boy coming for cough for a week, high fever for 3 days with crepitations. And this child has been put on coamoxiclav and admitted for persistence of fever. He has been put on IV amoxiclav and the counts are 7,700, neutrophils 49, CRP of 2.8, and the swab shows influenza A positive. And oseltamivir has been added because the report shows influenza A. So, Dr. Anil, in view of this report, will you stop the antibiotic which has been started earlier? And in general, what would be, the basis of either continuation of both the antibiotic and antiviral in a given child? So, would you like to just tell our listeners?
Yes, sir. Getting the swab done helps us in getting a lot of confidence in two ways. One is to stick to our antimicrobial stewardship and to stop the antibiotic. So all the labs here and getting the flu positive on the swab gives us a lot of confidence in stopping the antibiotic which has been started. And also at the same time tells us the importance of starting the appropriate drug like the antiviral oseltamivir and to continue with only oseltamivir. The swab and the clinical picture, overall picture, gives us a lot of confidence to withhold the antibiotic in such a situation.
Okay, that's great. Dr. Nathu, when such a situation arises, how would you look at it? And sometimes, our pediatric colleagues are hesitant in discontinuing the antibiotics. They feel that, it is better that I continue so that, if there is super added infection, no problem would occur. And, different thoughts come to their mind. So, how would you counsel our pediatric colleagues about being confident in discriminating one and continuing the other one? So, what is your outlook about this?
So, as rightly pointed out, getting a swab which has been positive helps us a lot in convincing the parents, our pediatric colleagues as well. There's a possibility of this super infection, which has been always been mentioned in literature, that around 15 to 20% of our patients of flu may land up with a bacterial infection as well, along with the influenza. But there is no role of antibiotics in preventing or prophylaxis of this infection. So the important thing is monitoring this patient, seeing that he's responding to our antivirals or not, or if he's worsening, and then deciding if we need to add an antibiotic. Otherwise, starting an antibiotic right away, thinking in terms of I would like to prevent a super infection, actually does not work. So oseltamivir only would be the way to go, and monitoring the child, seeing that is improving, and then if only if required, adding an antibiotic would be the ideal situation.
Right. So, we are all aware about the antibiotic stewardship, which we have been discussing. Now, we have had some cases where these cases of influenza went into complications related to the central nervous system. For example, this 1-year-old child with fever, cough, and cold came in status epilepticus, and nasopharyngeal swab showed H3N2, and the MRI showed non-specific changes of encephalitis. The CSF was normal, and he was diagnosed as influenza encephalitis. Dr. Anil, being an intensivist, I will like you to elaborate a bit more about the neurological complications of influenza and your experience about it.
Yes, sir. This season, I think we got quite a bit of children who had some CNS kind of a symptomatology and complications, and they landed up in the ICU secondary to the influenza virus. Majority what we got was the febrile seizures. Febrile seizures we keep getting, but this time because of the heightened fever in influenza, the number of febrile seizures we got secondary to influenza being positive was high. And couple of children, little older children, I would say adolescent children, because of the very high fevers, they landed up with febrile delirium, who required just symptomatic supportive care, and they improved. But one particular child I think we got was quite sick, toxic, started with the typical respiratory kind of acute febrile illness, and then cold, cough. Again, other family members were involved, and this child landed up in the ICU on day 3 with very high grade fever and multiple episodes of seizure, and the child was comatose in between. And when we evaluated, the MRI showed that bilateral thalami were lighting up, more like a necrotizing encephalitis kind of a situation. What we would typically see in a JE kind of a picture, both thalami were lighting up, and in between there were areas of necrosis also. And here we won't be able to demonstrate the direct viral invasion over here. The CSF obviously will be negative because majority of the manifestations were cytokine driven. It was more of an immune system driven where the CNS took a hit, and we had to initiate appropriate medications and immune suppression also in this case. And the child is recovered and doing well, thankfully. But all children may not be this lucky. I think again to after having seen all these complications, I would still say we need to start the appropriate antiviral much early in the course of illness to prevent all these complications.
Okay, that's very important. And then, of course, we had cases where influenza presented along with RSV, and we had to manage these cases accordingly. Now, we will have some questions related to the respiratory complications. And Dr. Nathu, in addition to the complications that we discussed, do you think of any other respiratory complications about which our pediatric colleagues should be aware of?
So these patients of influenza have this typical cough, cold, and fever with a lot of nose block many times, and they do land up sometimes with the symptoms of earache or otitis. And this is seen quite commonly. In fact, a couple of children out of 10 may have something to do, some symptoms related to the ear, maybe after 3-4 days of the onset of the symptoms. So otitis media is one of the common complications. We have seen several patients landing up directly with the lower respiratory type of presentation with a viral pneumonia, and especially in younger children who have eventually tested positive for influenza, they have presented directly with a viral pneumonia without any significant upper respiratory signs. As far as the complications are concerned, as was discussed, there are several patients who develop infections with the bacteria along with the pneumonia, and a child with, say, asthma tends to do a little worse off as compared to other children, because his asthma tends to get exacerbated and he needs to be treated with that as well. So these are the type of pictures which we are seeing as respiratory complications. A patient requiring, say, a ventilation or maybe a non-invasive ventilation has been seen this year. Maybe a few of them have been there who have had a severe pneumonia with influenza and who required respiratory support, either a non-invasive or an occasional invasive ventilation as well. So yes, a lot of patients with coming with respiratory complications.
And of course, we have seen children with toxic shock syndrome, a few cases of myocarditis and pericarditis, myositis, which we discussed, which is more with influenza B in 69-year-old boys, where bilateral involvement of the gastrocnemius and soleus occurs. And these are the children who come with severe bilateral calf muscle pain, inability to walk. And we also mentioned about the Reye syndrome in cases of influenza B who are exposed to salicylates. So a few questions finally to get some further clarity, some of which we have already discussed. Dr. Anil, an elder sibling of an 8-month-old child is admitted with influenza A for LRTI, and the 8-month-old child now has developed fever yesterday evening and have approached you. So will you start this child on Oseltamivir?
Yes, sir, definitely. Because already there is one family member who is already tested positive for influenza A. And especially this 8-month-old child will come in the high risk category. Anybody who is less than 2-year-old would come in a high risk category. I think no questions asked. We will go ahead and start this child on Oseltamivir even without getting it tested.
Dr. Nathu, in case if the child is not accepting the oral medicines, is there any alternative for Oseltamivir?
Unfortunately, there is no other alternative available commercially in our country. So oseltamivir is the only thing which we have. Fortunately, it is quite well accepted orally, fairly palatable. Hardly any child comes back with any problems with oral acceptance of the oseltamivir. If for some reason if the child is not able to take orally, then maybe the nasogastric tube would be the idea, and that is the only way in which the antiviral can be given.
Okay. And Dr. Anil, if there are some other household contacts in a family where the child is down with influenza, what is the policy about chemoprophylaxis to all these household contacts?
Yes, sir. Chemoprophylaxis should be avoided in the healthy household contacts. If you have a healthy family member, like an healthy parent, I don't think so we should be treating them with oseltamivir. But anyone with high risk, there may be an aging grandfather or a grandmother who is more than 65-year-old. They may have a chronic respiratory condition, COPD, asthma. They may be cardiac patients. They may be having a ischemic heart disease. I think our extremes of age group, less than 2-year-old, more than 65, or they are immune suppressed for whatever reason. It may be chemotherapy or a rheumatic rheumatological illness for which they are on immunosuppressive agents. All these household contacts should be started, or a pregnant mother. The mother may be pregnant with one more baby. So in these situations, we need to treat the household contacts with chemoprophylaxis.
Right. And then, Dr. Nathu, we have been using oseltamivir for influenza. So, what about para-influenza viruses? Does oseltamivir work for these patients of para-influenza?
Actually, it doesn't. Oseltamivir works only for influenza, different types of the influenza virus. It doesn't work in a para-influenza infection.
Right. That's very important because this neuraminidase is very specific for influenza, and that's why oseltamivir has to be given for children with influenza. So we have covered almost all the points related to influenza and the early use of oseltamivir, and now we can say that this virus is a fast and a furious virus with abrupt onset, high transmissibility, rapid progression even up to ARDS, and in addition, quick use of oseltamivir is also important for this fast and furious virus. Okay, of course, plain simple treatment is okay, but then prevention is equally important. And after the pandemic of H1N1 and COVID, we have become wise enough to follow this SMS, that is sanitization, mask, and social distancing, and cough etiquettes, coughing in the elbow, and certain rules related to the hand, like washing the hands, particularly in our medical field after examination of these patients, avoiding handshake, using a handkerchief, and keeping the people at a hand's distance, particularly in case if you or the other person has some upper respiratory symptoms, and also avoiding hand touching as far as possible. And of course, flu vaccine, which is to be taken annually by every one of us, because being in the medical field, we ourselves and our staff members, the nurses, the ayas, the ward boys, the receptionist, everyone has to be given a flu vaccine. And I always say that along with the sentence "Happy birthday to you," one should always remember "Happy birthday to flu." So on the day of birthday, the best thing one can do is to take a flu shot. And with that, we will come to the end of today's discussion. And I would say namaste, because already we have seen that we are going to start, saluting the person by saying namaste and avoiding handshakes as far as possible. So thank you for the patient listening. With that, I stop sharing the slides and I hand over the proceedings to Dr. Prashant. Thank you.
Thank you, sir. Thanks, Dr. Sanjay. Thanks, Dr. Anil. As usual, it was very lovely and lively. I'm sure the people, the audience has benefited out of interaction and clinical cases. Thanks once again. Thanks all the doctors who took time from their schedule and attended this webinar in the afternoon. Thanks IT team. Thanks Sanjana. Thanks Samriti. Thanks all of you. We can sign off, sir. Wish you a very pleasant evening. Thank you.
Thank you, sir. Thank you.
Thank you.